Respiratory System Part 2. I got cut off, but now I know when. YouTube promised that it was going to let me record for longer than 15 minutes, but maybe it forgot. I don't know. Anyway, I left off on sputum. I was talking about the fact that sputum is not saliva. Sputum is mucus and other material coughed up from your lungs and hopefully spit out. You don't want to swallow sputum because you've just given a fresh route for bacteria to get through your system. Try to cheer you up. Next word, stridor. We are on page 384. Tachypnea. Funny looking word. Fast breathing. And it can be indicative of a lot of different things. So, tachypnea. It'll show up a lot. Thoracentesis. Puncturing the chest wall to draw out air or fluid. Usually fluid. Thoracoplasty. Thoracotomy. Tonsillectomy. Tonsillitis. Tracheal. Trachealgia. Not a word you're going to see. I've never seen it besides in this book. Tracheolaryngotomy. Tracheostomy. A tracheostomy is different from a tracheotomy because a tracheotomy is just cutting into the trachea. A tracheostomy is doing what we call maturing the incision and preparing it for a tracheostomy tube that is going to be more or less semi-permanent. A lot of people do get off of a tracheostomy tube, but some people end up having a trach tube for life. And yes, you'll hear it called a trach tube very frequently. And weirdly enough, it's spelled T-R-A-C-H without the E on it. So, and then it's never a trach. Never. Tuberculosis. We talked about that. Wheeze. When you can hear a fine whistling sound with breathing in, breathing out, that could be a wheeze. And it indicates that your airways are constricted from either getting narrow on their own or being coated with sputum. And so a wheeze generally indicates you need to medicate with something. And there again, I am not a paid spokesperson. I recommend Mucinex. It works very well. Triaminic cough syrup also works, but it has a lot of alcohol in it. So, you don't want to give it to your 3-year-old. You don't want to give them Mucinex either, not without talking to a doctor. Drugs, antihistamines, decongestants, antitussives. And it's nice they give you 2 lists, one that is non-narcotic and the other that has narcotic agents in it. And narcotics often work to soothe the hyper-irritated bronchial tubes. And often they need soothing because you have coughed so hard so long. Expectorants. This is a medication that will cause you to expectorate, like Mucinex, so that it'll loosen up your sputum. Sometimes sputum gets so dry and sticky that it's really hard to cough it up. This is one of the reasons that when you have a cough, people are saying, push fluids, drink as much as you can, and then drink a little bit more, because it will help to liquidize your sputum and make it easier to cough it up. And certain medications will do that too. Mucolytics, something else that's going to break down mucus. And it could be a brand of cough syrups that they call mucolytics. Bronchodilators. Inhalational glucocorticoids. You're into some serious asthma if that is the medication that is being prescribed. Anti-tuberculosis agents. These are some really heavy-duty drugs, and almost all of these are fairly long-term drugs. And in acute phases, sometimes these are drugs that are delivered intrathecally. Thecal, thecal, and that means the sheath, and in this case it means the spinal cord sheath. So sometimes for tuberculosis, they have to put a needle into your spinal cord, or under the sheath in your spinal cord area, and deliver drugs that way so that they will go to the brain and to the nerves. Does that sound scary? Because it should. Lab tests, acid-fast bacillus, AFB, and it's usually called the AFB, and it's to detect Mycobacterium tuberculosis. Anti-streptolysin, O, sometimes called the ASO. That one I haven't seen as frequently. Certainly the AFB smear is a very old test and very reliable. Arterial blood gases, or ABGs. This checks levels of oxygen and carbon dioxide in your arteries. And it's not just any phlebotomist that can draw this blood, because they have to go to an artery, not a vein. And arteries are down closer to your bones. So it's generally a physician or sometimes a respiratory therapist who will stick a needle that deep into you to draw blood. Bronchoscopy. Nobody ever likes a bronchoscopy because we have to keep you awake for it, and we're putting a tube clear down into your bronchi and then into the right and left bronchi and then into smaller branches, and generally we have to keep you awake so that we can make you keep coughing when necessary so that you don't check or choke on your own sputum. Nobody likes that. Sputum culture, and that means we collect your sputum. We collect what you coughed and spit out, and then smear it on a slide, see what grows. Once we know what's growing, we know how to treat it, because we'll treat it with something that kills whatever you have growing. And it could be fungus, ew, bacteria, nasty things. Throat cultures, easy. You just get a long Q-tip and go back into the throat and collect whatever there is. Often we're looking for streptococcus. Laryngoscopy. That is a procedure that can be done in a ENT's office. That's ear, nose, and throat doctor. And will be done with a fairly straight tube down into your larynx. We can spray your throat with anesthetic so it's not so irritating. Nasopharyngography. X-ray examination of the nasopharynx. It sounded worse than that, didn't it? Sounded like they were going to stick things down your nose. No, we're just going to take a picture. Pulmonary function test. Pulmonary function test is a series of tests. You have to breathe in, you have to breathe out, you have to pull in as much air as you possibly can and hold it. You have to breathe out as far as you can and then a little bit more. And we're checking all kinds of things. We call it the tidal volume. That refers to going in and out like the tides. So how much air are you breathing or moving? Vital capacity, the forced vital capacity, expiratory reserve volume, residual or functional residual capacity, maximum voluntary ventilation, and total lung capacity, and flow volume loops. And the interesting thing is some of these are relatively new and some of these are very, very old. And I've seen these initials change over the years. So as we get more specific with what we need to test for, we are more able to name them appropriately. And a rhinoscopy. I don't know about you, but that makes my eyes water just to think about it. They're going to go up your nose with the scope. Don't want to think about it. Abbreviations. What ones are really critical that you should know, memorize? ABGs, absolutely. AFB, yes. AIDS. The key word on AIDS is acquired immunodeficiency syndrome. Acquired means you catch it from somebody. And there are ways to avoid that. ARD, ARDS, yes and yes. CF is used as an abbreviation for cystic fibrosis only if you commonly work with cystic fibrosis patients. CO2, absolutely. COLD, I've never seen that before except in this book. COPD, all the time. Major. You should write COP down. You should know what that means. Chronic obstructive pulmonary disease. These are people we call the lungers. And they'll come in, they are still in not dire straits. They're called a pink puffer because they still are pink. And they're breathing. And then you get the blue bloaters. Not good. They're blue around the mouth. They're clearly lacking in oxygen because they are not getting enough air. CXR, chest x-ray, absolutely. ENT, yes. No. ET, yes. HIV, yes, you should know that. HMD, that is primarily associated with premature babies, hyaline membrane disease. Hyaline membrane being a membrane in the lungs, and when babies are too premature, they don't have a surfactant, so that when they exhale, their lungs are still sticky and they stick together, so they're not getting enough oxygen. Very critical to treat that in the preemies. IPPB, intermittent positive pressure breathing. And that means you are hooked up to a respirator, and as you breathe in and breathe out, it doesn't let enough go out that your lung will collapse. So it keeps a positive pressure in there. IRDS, very alike to ARDS. IV, you should know that. You should just know that by now. NSAIDs, non-steroidal anti-inflammatory drugs. You should know that. O2, absolutely. PE for a pulmonary embolism. Yep, you need to know that. Blood clot in the lung. PEEP, positive end expiratory pressure. This is a ventilator setting, just like IPPB is a ventilator setting. PND, two meanings. One, not so bad, postnasal drip, that's that running down the back of your throat, smelling bad, making you cough and hack. The other one is paroxysmal nocturnal dyspnea. That's where usually you're sound asleep and all of a sudden you find yourself sitting bolt upright, gasping for air. And not a good sign. PPD is a tuberculosis test. RDS, respiratory distress syndrome. RSV, we talked about that one before. SIDS, sudden infant death syndrome. We're still not sure what causes that. My time's going to run out. SOB, very, very important. You should know that. TNA and URI, critical. You know those terms. And I think it's going to cut me off, so